So this is one of our studies in which we assess both the oncological and also the hemodynamic parameters. And what we have seen is in the immediate post-op, these patients tend to have slightly higher fluid requirement with tachycardia and slight hypotension compared to the preservation group. However, it stabilizes by 48 hours. So this happens in the initial 48 hours. And we didn't find any significant difference in the lymph node yield. So the consensus as of now is no routine thoracic duct excision from large systematic reviews and indicated either to prevent chyle leak, especially if you're going to do a three-field lymphadenectomy, or uh, when there is a direct involvement of the thoracic duct by the tumor. Since there is no role for routine thoracic duct excision, so we need to find ways to preserve, despite some anatomical anomalies. So there are various methods. One is use of fat-rich diet. One of the techniques is use of olive oil, and then mix it with methylene blue. The only limitation of this is it does allow you to visualize a thoracic duct only after removing the fat around it. The one which I think now most of us would be using is the ICG lymphangiography. The main advantage is it allows you to visualize a thoracic duct without complete dissection of the fat around it. And that's the main advantage compared to the traditional methods of thoracic duct preservation. A typical case is shown here. So we are not seeing the thoracic duct. So now the camera has been inverted. We are looking for the thoracic duct in the standard place. That is, this is the descending thoracic aorta. This is the azygous vein. And usually thoracic duct is present here. But it's not obvious as in the previous case. And these are the cases where ICG can be really useful. So the moment you activate the NAR mode, then you can clearly make out where is the thoracic duct. And as highlighted before, it's useful in cases, in difficult cases, and also in those with anatomical abnormalities. Now, the ICG lymphangiography, there are various techniques of doing it. The commonly used is ultrasound guided injection into the inguinal node. Many studies have mentioned use of ICG per kilogram. I think one thing we need to remember is the ICG dose has to be calculated per kilogram if you're going to use ICG for assessment of liver function. For all other indications, calculation based on kilogram is not a mandatory prerequisite. You can use an absolute dose. I think that's something which we need to remember, because actually sometimes when you calculate per kilogram, you'll be giving more ICG than actually required. So here you can actually dilute it to 10 ml, so that then it becomes 1 ml becomes 2.5 mg. So you inject 2.5 milligram of inguinal of ICG into the inguinal node on either side. And generally it's done at the time of induction of anesthesia. And usually you can visualize a thoracic duct approximately 1 hour after injection. This is the preferred method for ICG lymphangiography. And the other technique is subcutaneous, either into the dorsum of the foot, but recently there are reports of using it in the inguinal region, that is subcutaneous plane in the inguinal region. So the advantage is you don't have to use ultrasound to target the nodes. You need to give slightly more dose compared to the 2.5 mg. So you give 12.5 milligram, which means 5 ml. And you give both above the inguinal ligament and below the inguinal ligament. Less volume above and more volume below the inguinal ligament. And this can be given because here it does take slightly more time than injecting into the inguinal node. So the advantage, you can even give the previous day also, the night before the surgery, and you can visualize the thoracic duct. There are some studies where the similar technique has been used even at the time of induction of anesthesia, similar to inguinal node, and they also reported. But the amount of literature on the subcutaneous injection technique is lesser than the injection into the inguinal node. So the standardization is less with the subcutaneous injection. There is also one more route, which is not routinely used, but can be, good to remember is you can actually inject into the subserous of the intestine, close to the mesenteric border, and that's also a technique to localize the thoracic duct.